Good afternoon. My name is Prakash Muthusami. I'm one of the pediatric neuroradiologists at SickKids here in Toronto. I'd like to thank Timo and the other organizers for giving me this opportunity to share with you some of our experiences here at SickKids with non-endovascular procedures in the head, neck, and spine of children. And obviously, this includes a spectrum of procedures, some of which are more generic, like catheter insertions, injections, and biopsies, but also some more specific procedures. And if some of you are also performing non-endovascular procedures, I'll also talk about some strategies which you can use in the pediatric world for these procedures. So over the next 15 or 20 minutes, I'll show you some clinical instances where we have used some of these strategies and techniques for a variety of procedures. First of all, there are obviously specific considerations in children, not the least of which is that these patients range from a baby less than 2 kilograms to a teenager more than 100 kilograms. Like in the endovascular world, the devices are made for adults, and therefore it behooves us to modify our approach and plan for each individual case. We also take a lot of precautions and techniques, obviously, to reduce radiation. Ultrasound guidance is a big technique in our toolbox. The use of cone beam instead of conventional CT, and some software modifications like image fusion or multi-modality guidance are some things that I will talk about. We also collaborate with our medical physicist, Nick Shkumat, seen here in the inlay, to ensure that all our X-ray doses, especially cone beam, are optimized. For example, the cone beam CT doses that we are currently using are 1/10 of the factory standards. But also to make sure that in these procedures, the benefit to risk ratio remains as high as can be reasonably achieved. Now, we are dealing with kids with rare conditions and unusual conditions, and often we come across a procedure which we are not doing frequently, and therefore it's important for us to collaborate across with our clinical colleagues, whether neurosurgery, ENT, or anesthesia, but also at times with our body interventional colleagues because they have a lot of tools and tips and equipment which we are not familiar with. Last but not the least, like any pediatric procedure, we are dealing with the anxiety and expectations of the parents, and that becomes a big factor for these procedures. Take the example of the 6-year-old girl who came a few days back actually with upper back pain and this small mass in the neural foramen. What would be the best approach if the oncologist wants to biopsy? Should we just wait and watch this and assume it's a benign mass? Should we go ahead with a conventional open surgical biopsy? As neuroradiologists, we would tend to want to do a CT-guided biopsy. And I think for most of us, that would make the most sense. Remember, however, that in children, ultrasound gives you a very good window into the pediatric body. And this image here shows you very nicely how the mass can be beautifully depicted, the margins of the bone and the pleura distally. And this biopsy can be done under real-time guidance without the use, and you can see here one cone beam CT acquisition to confirm before we actually fire. So ultrasound is your friend for a lot of pediatric procedures in the head, neck, and spine, with the advantages being no radiation, real-time guidance, as well as a decreased procedural time. On the flip side, you can have artifacts and limited windows, especially around bone. And I think also the fact that as neuroradiologists, we are not trained to use ultrasound to do procedures, and that becomes part of a learning curve. But superficial structures like the temporomandibular joints are mostly ultrasound accessible, which we use in the JIA population for steroid injections, and similarly salivary glands, which we use in the CP population who has excessive sialuria with excellent results. Biopsies of lesions which are superficial and vascular can also be performed safely with ultrasound and nothing else. So look at this boy with a cheek mass, very vascular on angiography, no shunts. Facial artery coursing right through it, all of which is seen on the ultrasound. You can see the facial artery branches and avoid it using ultrasound. Similarly, this lytic lesion in the skull, the ultrasound shows you exactly where the biopsy needle is, the margins of the bone, and the dura. And you can perform this biopsy was done in under 5 minutes. Sometimes, like we saw in the neural foramen, deeper lesions can be ultrasound accessible too, like this prevertebral / parapharyngeal mass, which is infiltrating the vertebral artery and pushing the carotid sheath. And all these vascular structures are nicely depicted on the ultrasound, and a real-time biopsy is obtained without the need for CT or radiation. Because we get such a good view into the infant spine, we use ultrasound a lot for lumbar punctures, which are referred to us from the neonatal ICU. But this is typically not the picture that we get. We get a moderate epidural hematoma, we get engorged epidural veins, and typically it is common for us to see a small CSF stripe like this. Now let me tell you that fluoroscopy is often inadequate for this sort of a lumbar puncture because the elastic dura in an infant is simply pushed even by a 25 gauge needle and not actually popped. But with ultrasound, you can actually target these pockets of CSF. And this is a procedure which can be done with the child awake. It doesn't need anything other than a little bit of local anesthesia, and it can be done at the bedside, as you can see here in the NICU. Some procedures, however, are still well suited for fluoroscopy, which still has the advantage of real-time guidance, and as neuroradiologists, it gives us a familiar bony landmarks. One example is disc biopsies, just like we would do it in an adult. I use the standard Scotty Dock technique, get subchondral as well as disc biopsies, like in this 12-year-old boy with disc lesion who turned out to be osteomyelitis. This was a 13-year-old girl who had this giant aneurysmal bone cyst. Incidentally, an MRI had been performed for some other indication 10 years ago and was completely clean, but at the age of 13, she has this giant aneurysmal bone cyst. We initially performed a transarterial embolization as a pre-surgical devascularization. Intraoperatively, she developed a dural tear, because of which she developed a large pseudomeningocele. After 2 days of increasing intracranial hypotension, we brought her to the suite, and you can see the 2-high needle going past the surgical hardware. We inserted a lumbar drain, and you can see the other catheter in the other drain. 2 weeks later, complete resolution of the pseudomeningocele, and there is also some early bone remodeling. So this case exemplifies not just can we assist with the pre-surgical devascularization, but also with complications that may arise as part of the surgery. This is our multidisciplinary, multi-professional vascular anomaly center here at SickKids, and along with our colleagues, we see a lot of, a variety of vascular malformations and tumors, and a lot of them obviously are in the head and neck, like in this 9-year-old boy with a painful masticator space slow flow venous malformation, intricately associated with the internal maxillary artery, both of which are beautifully depicted by the Doppler ultrasound used to get access, fluoroscopy used to inject 3% sodium tetradecyl sulfate. And these patients often require 2, 3, or more sessions according to symptomatic response. For VMs that are more superficial, we have injected percutaneous NBCA, like this 13-year-old girl with a superficial VM over the temple, and a second VM with a suspected sinus pericrania, which we initially did a cerebral angiography to confirm non-dependence of the intracranial venous outflow, following which we isolated the VM with percutaneous glue, and then we could fill the lesion as a unit for the surgeon to resect and block. And this is a procedure which can be done either immediately before the surgery, or it can be done a few weeks before the surgery once the swelling dies down. This 2-year-old girl came with acute proptosis and decreased vision from acute hemorrhage into an intraconal lymphatic malformation. The surgeons initially, the ophthalmologists, initially did a canthotomy and release, attempted to drain some of these collections of blood. 5 days later, she comes back, even larger expansion, more proptosis. You can see the stretching of the optic nerve has increased. So we put drains in under ultrasound guidance. We did sclerotherapy with bleomycin. A 5 French drain left in place allows you 2 or 3 sessions as required. She had an excellent outcome. This is her 6 months out. She has only the telltale sign of the lateral canthotomy, but little else. In most of these cases, you still see some residual disease in the MRI. You can also see some optic nerve buckling, but she has remained asymptomatic without recurrence. We use CT guidance for procedures like bone biopsies or bone ablations, like in this 10-year-old boy who had an osteoid osteoma in the lamina of L4, and you can see how closely it abuts the facet joint. A lot of peritumoral inflammation. He underwent laser ablation under CT guidance with excellent clinical outcomes. Now, these are procedures that we do in collaboration with our body colleagues, Dr. Temple, seen here, who does a lot of these procedures also outside the axial skeleton. I had spoken a little bit about needle guidance. That is, I think Vitor was talking about cone beam earlier today. Needle guidance is a software that we use when we do a lot of these biopsies, especially for lesions that are well seen on CT. It allows you to target a lesion without having to do a real-time CT guidance or multiple CT sections. The biopsy itself can be performed with a biplane fluoroscopy, so we are using a live image. And you can see here, once we plan the trajectory, the biopsy itself becomes a quicker procedure than having to do it under CT. Now, for a lot of these lesions, which are typically small in smaller children, we use smaller gauge needles. This was a 20 gauge needle, and smaller throws, like a 10 millimeter instead of a 20. And it's important to discuss that ahead with the pathologist, because they might assume that the samples you're giving are actually insufficient. Some lesions could be MRI better visible or MRI only visible, like bone marrow changes in this boy who had a history of nasopharyngeal carcinoma. MRI has the advantage when doing procedures with MRI of multiplanar imaging, multiparametric imaging, and if required, sequences for temperature monitoring, with the flip side of a cost and time penalty of performing these procedures in the MRI scanner. Also, even equipment and our devices which are MRI conditional or compatible also give a lot of blooming and susceptibility. You can see a 20 gauge device looks like a 10 gauge device under MRI. But with lesions such as this, which are more superficial, a surface coil can bump up the SNR and improve visibility. The other option is to actually bring the MRI environment into the IR environment instead of doing the procedure in the MRI. And we have started using that for a lot of cases which are, again, better seen on the MRI. Smaller lesions increase the confidence of performing a procedure with those lesions. And we call that MRI cone beam fusion. A good example is this small Tarlov cyst in a 14-year-old girl who was a competitive dancer but had to stop classes because of excruciating pain. You can see the distortion of the nerve root here. Now, this lesion could be seen on CT with regard to the scalloping of the bone, but not the cyst itself. Obviously, this is by any means a small Tarlov cyst. So this was an ideal case where we could actually fuse the cone beam CT onto the MRI, plan our trajectory of the bone drill with the MRI image, and the injection of fibrin glue into the cyst is actually done by using a live fluoroscopy image onto which the 3D MRI is fused. This MRI is 1 week out. You can see already there's a collapse of the cyst. Some signal of the glue is seen inside the lesion. Last month, she came for a 3-month follow-up at the clinic, and she is asymptomatic. She has restarted her dance lessons. Finally, a word on multi-modality guidance. A few days back, we saw this 2-year-old girl with severe lower back pain because of this collapsed vertebrae, L3 level. And there's a soft tissue component in the level of the body, and also a small soft tissue paraspinal component. Now, the first discussion obviously becomes how required or how important is this biopsy with a radiological diagnosis of Langerhans cell histiocytosis. But if the oncologist is not willing to wait and watch, how safe is a biopsy when the pedicle is smaller than the biopsy devices that we have? When the soft tissue, even when we mag it up, it's not even a centimeter. So even when you mag it up, it looks small. A standard posterolateral approach is usually not possible at this age because the psoas muscle has not yet developed and you don't have tissue to go through. Now these are examples where we would use information from a number of modalities. So we used ultrasound and fluoroscopy to actually plan our trajectory into this soft tissue lesion, which is seen well enough on the ultrasound. Confirmed with cone beam CT that we are indeed within the lesion. turned on the MRI fusion, which confirms that the biopsy device is well within the limits of the lesion. With the needle guidance, a real-time biopsy can be performed. Now, this looks like an elaborate setup, but once we are used to the steps of each of these, each modality actually adds a single element to the jigsaw puzzle. And it doesn't actually increase the procedural time. We find it decreases procedural time. And this was the biopsy with a standard 20-gauge system. And you can see how information from a number of systems can be married to increase the safety and efficacy of a procedure, but also at the same time decreasing the risk and the requirement for radiation. I'll leave you with this slide. Ivan was talking earlier today about the hybrid suite. This is our hybrid suite, which came up last month actually at SickKids. We are yet to use it for anything other than diagnostic MRI, but we look forward to a lot of potential in terms of interventional cases and collaborative cases. So I will summarize that there are a lot of non-endovascular opportunities for a neuroradiologist to add to a pediatric IR service, which has specific requirements, and those have specific solutions. One of the keys is, of course, multidisciplinary collaboration. And as we have seen, the use of multi-modality image guidance and being comfortable with all those to put them together in a case. At SickKids, we are fortunate to have a long-standing tradition of collaboration, not just within our department, but also across departments and even across the street with our adult colleagues. So with that, I thank you for your attention.